Welcome all of you. My name is Manzoor Ali, and today we are going to discuss about the MRI abdomen. And this all the contents: basic workflow, patient preparation, positioning, protocol, and pathologies. So let's begin with the basic workflow. Here I have divided the areas in the MRI into different. Uh, the reception desk, nurse preparation area, waiting room, and scan room. Next, the persons also divided here. So there's we have the patient, reception staff, nurse, and MR technologies. Now let's see what this persons will do with respective the work areas. The patient will be arriving at the reception, then they'll be heading to the reception desk, then the reception staff will do the registration. So once the registration is done, the patient will be handed over to the nursing staff, and the nursing staff will take the patient into preparation area where they will do a screening will be done here. So there will be a screening form with multiple questions will be there, and the screening of the patient will be done here about the patient histories, etc. Then IV placement. If the patient is indicated for a contrast study, then IV placement should be done. So that will be done here by the nurse. So once this is done, then the patient will be going back to the waiting room. Here, the reception staff will notify the MR technologist that the patient is ready for the scan. And now the patient is there with the MR technologist, and the MR technologist will take the patient into the MR waiting room, and here there will be a screening will be there. So this is a re-screening. Patient will be re-screened here. The thing is that the next the patient will be taken to the scan room. So before that, we have to assure that the patient is okay for the MR scan. Rescanning will be done, and then we'll ask the patient here to change the dress into the hospital gown. So when the screening and the dress changing is over, then we'll take the patient into the scan room, perform the scan. After the scan, the patient can dress up and he can leave the department with the films, and the report usually it will be after some time. So this is a basic workflow in the MR department. Now, moving to the patient preparation, here appointment should be given. So need of this appointment is that the patient won't feel happy to wait in the radiology department. Even if they're waiting in the wards or the hospital room where they are or their home, they won't feel that much discomfort, but they'll feel a lots of discomfort when they're waiting in the department. NPO should be there 4 to 6 hours. This will reduce the ghosting artifact due to the peristalsis. Get the clinical history, which is very important for the radiographer to alter the scan or to do some special sequences or to concentrate on a particular area, and also for reporting. It will be helpful for the radiologist. And check the serum creatinine report if the patient is indicated for an contrast study. The patient preparation in the department. Here, we'll weight the patient. We have to check the weight of the patient, then that has to be entered for the calculation of SAR. So we'll enter the weight into the system, and system will calculate this here. Here, the next is that we'll ask the patient to wear a hospital gown. So patient had to change into hospital gown. We'll head the patient to the changing room. Here we'll ask the patient also to remove the metallic objects. Patient had to remove the metallic objects, and if any other objects are there with the patients, include the phones, keys, etc. Then a screening for the metal objects should be done. So these things will include the implants, pacemaker, prosthesis, denture, stents, etc. Next is that we had to take a consent. So there a consent has to be done. This consent should be written and informed and explained nicely to the patient. And safety questions will be here about like the history of any previous allergic reactions or the surgeries, etc. And once this is done, then the next is that in case of if the patient is indicated for a contrast study and there is no an IV cannula, we can there will be the placement of IV cannula. So this is only for the contrast if it is indicated the contrast. And once a cannula is placed, you can check whether it is in the exactly in the IP or not. Next, uh, in case if the patient want to contact with the radiographic technologist during the scan that the patient is not feeling good or something, we can give an emergency visit to the patient. And if the patient need to contact with the technologist, then the patient can use emergency visit. Without instructions and trials. This is very important that the sequences what we are using here for the abdomen will be with the Brithol and without the with Brithol also. So there will be many sequence with the Brithol action. So the Brithol sequence is then we have to inform the patient. The patient had to hold the breath once we are giving the instructions. And after that, if you're giving a trial, it will be very good there. So you can ask the patient to hold the breath and you just check it that the patient is holding or not. So give a trial 1 or 2 times or 2, 3 times. It will be better during the scan. Explain the complete procedure. It will take this much time and there will be sounds will be there and the patient should not move. So explain those things. So when this is done, now we'll start with the we can start with the scan. Here, the patient positioning and central ray. Patient is positioned head first or feet first supine, and hand overhead or side of the trunk also can be kept. But it's always better to keep overhead to reduce the artifacts. A patient will be positioned over the spine coil, and over the patient there will be the abdominal coil or the body coil. And during the placement, this abdominal coil will be placed nipple line. The upper part of the coil will be on the level of the nipple line down to the iliac crest. And you can give the patient some cushions under the leg for the support. And the central ray, Cepheid process is a central ray. I will center over the Cepheid process and tight the coil. Now we'll move to the sequences. So always the scan will be beginning with a lock laser, a 3-plane lock laser, and after that T2 blade axial laser, and then a T2 FS blade axial laser. So one is FS and another one is just without FS. Then T1 by FS 3D coronal, T2 trophy coronal, and in phase and out phase axial, T2 in phase and out phase axial. Then T1 pre-contrast is 3 mm. Next is we'll give the contrast. Then a care bolus is which is for tracking the contrast. After that, T1 3 mm dynamic scanners. Then a delay is T1 same the T1 delay scanners. The delay will be varies according to the area of the interest. Usually for the liver it is 20 minutes and the pancreas is 5 minutes. Here I'll be using 2 types of sequences. That is a Brithol sequence and triggered sequence. And there are some difference between both of them. Brithol sequence here, the patient has to hold the breath during the sampling. So when the scanner is going on, the sampling time, the patient have to hold the breath. The next is that triggered sequence. So triggered sequence here, patient no need to hold the breath. The machine will monitor the respiratory motion and accordingly the machine will do the sampling. So if we want to, if the patient is good, and we can reduce the time to 20 seconds and some seconds and ask the patient to hold the breath. So that's a Brithol sequence. Or else if it is a 40 seconds, we can divide it to 10, 10, 10 like that. 4 times we can ask the patient to hold the breath. And once 10 seconds is over, then we'll ask the patient to leave it and calm. And after that again last hold. So this can be repeated. So they are the Brithol sequences. And so the first image was the Brithol sequence. There is a normal planning only. There is nothing extra other than the slices boxes. But in the triggered sequence, you can see here a small box which is called as a navigator, and this will be placed half over the diaphragm and half over the lung, okay, half over the liver and half over the lung. So this will monitor the respiratory motion and accordingly the sampling will be done. Now we'll move to the workstation here. The first thing is that we are registering the patient. So during the registration, we have to enter a lot of some details here: the patient name and the patient ID, then the date of birth, and after that the gender. And once the date of birth we are entering, the age will come here automatically. Then the height and weight of the patient. So that is needed for the calculation of the SAR. We can see the all the bolded areas. This all the bold written area, they are needed to start the scan. Until we are done that, that is the exam option won't be. We won't get the exam option. So when that is done, then we had to select the study accordingly what we are selected. So all the preset studies will come there. So which one we want to do here, that we can select. So abdominal routine, which is I have selected here for the patient, and about the patient position, how the patient position, whether it is head first or feet first, supine prone. Okay, how we are positioning. So here I will be positioning the patient head first supine. So selected head first supine. When this is done, then we'll move to the exam. And here we can confirm that the patient name, weight, what is the question we are doing. Confirming here, now we are entered to the workstation. Here, the right side, we have the sequences. This all the sequence we are going to use here. So we'll be begin with the localizer first. Localizer with it's a 3-plane localizer. We'll get 3 images here: axial, coronal, and sagittal. And after that, so we got the localizer image. We can drag it to see here. And now we are planning the T2 blade sequence. So the anatomy was not covering, so I increased the slices to 30. And the axial, which had to cover from the superior part of the liver to the inferiorly the enter the kidney. So this is a planning, and so it has to cover from superiorly the liver and inferiorly to the kidney, and make it that the slices are perpendicular to the spine or vertebral body. So when that is done, here the FOV is a little bit anteriorly, so we can keep it down. And this is actually that navigator. Okay, navigator. This navigator had to keep half of the liver and half over the legs. Okay, so keep it a little bit up here, and after that, therefore, we am keeping down. Now the area of interest is in the center of the FOV. So when this is done, we can apply. So this is the triggered sequence. The patient no need to hold the breath; it will automatically. So once we'll apply this, and after that, we have the next sequence. There is a T2 blade FS sequence. So what we have done is, what we've done here, it is a T2 blade. Next is a T2 blade FS. Before going to that, here what we have done currently, that is a navigator sequence, triggered sequence. Now we'll show you how we can convert this sequence into a breathol sequence. The same sequence, I'm keeping it down, opening here. Here a face option is in the face option, you can see trigger, breathol, and monitor. Okay, so here we can select how we had to how we had to do the scan. Okay, so we can select the breathol sequence. So once you're selecting the breathol sequence, then the patient had to hold the breath during the scan. Now heading the next sequence, that is a blade FS sequence. So we got the blade images. I can drag it here. So it's covering from the superior of the liver completely. The under the kidney is covered here. The planning of the T2 blade FS, it's same as T2 blade what we had done in the upper. No, it is T1 wipe 3D coronal sequence. So here covering the anatomy, and it is triggered sequence. Moving the next is another coronal, that is a trophy coronal, T2 trophy coronal. So this is a breathol sequence. We made it to triggered sequence. Navigate is keeping over the area, half over the liver and half over the lung area. Applying. And if we don't want to do that, then we can change that in the face area. Here breath hold sequence we can select. Only selecting the breath hold, then there is no any navigator options. Okay. Now it is 39 seconds, which is a little bit difficulty for the patient to hold. So you can reduce the time. 39 seconds in a single breath is difficult for the patient to hold. So reduce the time with adjusting the parameters. So that will help the patient easy for holding the breath. If you can make the time some 20 seconds or 18 seconds, it will be easy for the patient to hold the breath. Now we are moving to the next sequence, that is the in phase and out phase. So it's an in phase and out phase. Here there will be two TE, TE1 and TE2. One TE is 4.76 and another TE is 2.39. So single sequence have two TE. About the sequences will be explaining later. The planning is same only how we are done it for the axial. All the axial plans are same here. So you can just copy parameters can be done here. And it's a breath hold sequence. So here you'll ask the patient to hold the breath, and after that I can press here. So the sampling will be doing. When the sampling is over, then I'll ask the patient to leave the breath and be calm. And after 5 to 10 seconds, again I'll ask the patient to hold the breath and again continue the sampling here. So here I forward a little bit. And next is again we have a T2 sequence with the multiple TE, that is a T2 plus T2 TSA. Here also two TEs. Then the T1 axial now. So the parameters is same here again. Sorry, the planning is same here, and it's a triggered sequence to keep the navigator on over the area, and a diffusion sequence. So diffusion also axial. Here B value. The B value for what is here is 0, 50 and 800, and 3 B value is already here. And if we want to increase one more B value, the upper option is the diffusion weighting option. So there we can increase it, make it 4. So if you're making it 4, we can enter here what B value we have to add here. So accordingly, we can add here the B value. So this situation, we need only 3 B values, So plan is same as the other axials. The FOB is not covering actually the entire area, so I'll just increase FOB here. So already 250, 350. Okay, 350 is little more, so you can reduce into a 320. Moving down, next is a T1 flash. It's a pre-contrast sequence. Axial pre-contrast sequence. It's a T1 sequence, and also it's a fat saturator sequence. FS sequence. So it's a 17-second sequence. 17 seconds is fine. That we can ask the patient to hold the breath. Now we open trophy here. This is a trophy image, and we'll check that whether it is covering the entire liver and the kidney or not. So a little bit kidneys cut is it. So what we can do, we can increase the slices. Slice per slab, it's 40. Now we made it to 48. Yeah, it's covering now. So it's a breath sequence. Now it is 20 seconds. We increase the slices. That's it's become the 20 seconds. Applying here. Till this we have done the pre-contrast. Now we have a test bolus sequence here. Okay. So the test bolus sequence, you can see here how it's kept. It's over the heart, cardiac you can see. So what we can see the contrast is reaching there. This sequence have only one slice, and here you can see it is 1 minute. Total scanning is 1 minute. So one slice that's scanning 60 times. So each second we'll get one slice. each seconds will get one slice. The same areas will it will be repeating again and again. Now you can see the 60, if I'm reducing into 59, the time also will reduce to 59. If you are reducing it again to 58, the time also reduces to 58. So this measurement, you can see each sequence what is the time starting and ending. So we'll keep it 60 only. And after 60, we are applying that, but the scan won't run. Okay, we have to continue the annual scan run. Now the post contrast sequence, that is a dynamic sequence also. We get the planning is same as the axial, but the dynamic here you can see the measurements. Okay, so test borders we have seen that the measurement is 60 here. It means 60 times scanning. Now the scanning time is 17 seconds and the measurement is 1. It means how many slices is there with the sequence, that is T1 class dynamic, that much will do, and after that it is over. If is increase this measurement into 2, then 2 times it will scan. 3 times means 3 times. Same area after one scan, it will scan one more time. 3 times, 3 times it will scan. Now there is an option is it pause after first scan, second scan, like that. Okay, so we know that CT scan will be all of them will be very familiar with that. In the arterial phase, venous phase, portal venous phase, there is some delays are there. It's the same technique we are using. Once we are tracked the contrast, that is with the test border sequence, then immediately we'll start the scan here. Okay, so that will be the arterial phase. Now here, see if you're making 2 measurements. So after the first scan, that is the arterial phase, we'll keep a delay here, a 15-second delay. That is to start the portal venous phase. Okay, and now we are made it 3 measurement. That is a 3 scan. So after first scan, there is 15-second delay. After second scan, we can make it some more delay here. Okay, so you can make it 5 seconds. But if you're making it 5 seconds, there will be issue will be there. After once the second scan is finished, patient will get only 5 seconds to deep the breath. Then patient have to hold the breath again. So it is there's a chance of movements in the next next images. So what we can make, we can increase the timing actually from the 5 to 8 or 10, something like that. Okay, so we'll increase the time to 8 seconds will be fine. Okay, 8 seconds. So that is done. So the total time is 1 minute and 15 seconds. This will include the scanning time, delay time, all those times. Approximately, if you are increasing the slice to 48, the scan time will be 20 seconds. Balance all of the delay time. We are applied. Now contrast is given continuously 1 second, 1 second. We'll get the scan. Okay. So little bit I skip here. So here we got the contrast. Okay. So here we got the contrast. Once we get the contrast, then press the stop button immediately and continue the next sequence. Immediately within 3 seconds, it will start the scan. So by the time we can ask the patient to hold the breath, the patient will be holding the breath. So once that is done, we'll get arterial, portal venous, and venous phase. Then we need a delay phase. So according to the time, how was that? What delay is needed? We can plan one more same sequence without the with a single measurement. Only one in the scan will be there. Okay, so this will be planning accordingly that what is the delay is needed. So it will be varies with the patient's conditions or patient clinical history. Now we'll move to the in phase and out phase. This sequence we are using in the abdomen. Here, the proton in the fat presses slower than the proton in water. Both the protons in fat and the water, the precision is different. So one is slower, the fat protons are slower comparing with the protons in the water. So some points where the proton of fat and the water, they will align, and that is they are in phase. And there are some other points where the protons of fat and water, they will be opposed, and that is out of phase. When they are in phase, that means when they are aligned, that time the signals will be added, water plus fat. And when they are out of phase, they are opposed, that time the signals are subtracted. So this addition and the subtraction of the signal will be done when this are in a single voxel, when they are in a single voxel. The image here, the first one is an in phase and the second one is an out phase image. And easy understanding in the image is that surrounding the organs, abdominal organ, there is a hypointense plane we can see. It is an area where the fat and water is present. So that's why that area is hypointense. The signals are could cancel here, and we're getting an hypointense area, which is seen in most of the abdominal viscera, surrounding abdominal viscera, that the water contains in the organs and the fat in the abdominal cavity. The TE what we're using is 2.25 milliseconds for the out phase and in phase is 4.5 milliseconds. Now we'll discuss some pathologies starting with the HCC, hepatocellular carcinoma. In this case, here four images are there: T2, T1, and arterial phase and portal phase. Hepatocellular carcinoma, this will be hyperintense in the T2. Okay, so here it is hyperintense. Hyperintense means this is comparatively with the liver intensity. The lesion is hyperintense, and in the T1 it is hypo. It's hypointense. So the characteristic of this hepatocellular carcinoma in T1, it can be hypo or it can be hyso also, or very rarely it can be hyper also. Hyper is actually due to that intratumoral fat will be there. So that time those will be look like hyperintense. All other conditions it will be completely hyper. But T2 is slightly hyperintense. Then moving to the arterial phase, the main characteristic of this HCC is that they will be enhancing in the arterial phase, early arterial phase. They will be enhancing with the early arterial phase and wash out immediately. So the first one, so the D, this is a this picture is actually the arterial phase, which shows an enhancement of the lesions. Where here, this one, here enhancement is not there, which is a portal phase. So immediately after the arterial phase, there is a washout result. So this is a characteristic of the HCC. We'll see one more HCC here, as a T2 weighted image shows a slightly hyperintense. Diffusion restriction are seen. This both are the diffusions. B and C is the diffusions. Slightly restrictions can be seen here. After that, the D is an arterial phase, which shows enhancement of the contrast. Then late in the portal phase and the delayed phase, there is no any enhancement, but there is surrounding enhancement as seen. Surrounding enhancement is it, but the lesion is completely hypointense. There is no any enhancement, so that is a washout. Moving to the next, hepatic hemangioma. Here we have the four images: T1, T2, arterial, and delayed phase. Hepatic hemangioma, they are hypointense relatively to the liver parenchyma. So in T1, they are hypointense relatively to the liver parenchyma. Here the lesion is very hypo comparing with the liver parenchyma, and the T2 it will be hyperintense, and that's related to the liver parenchyma. It will be hyperintense, and also this intensity won't be that much hyper like the fluid or the CSF, etc. It will be less hyper comparing with the CSF. Now we are moving to the next here, arterial phase. Arterial phase shows no any enhancements. So the lesion you can see it's completely, there is no any enhancement, but there is some peripheral enhancement is it. So the main characteristic of this hepatic hemangioma is that there won't be early enhancement in the artery, or there won't be any early enhancement. So after the contrast, the enhancement usually will be seen 5 minutes or after 5 minutes. Now this is a delayed image which shows there is enhancement is seen in the delayed image. So the characteristic is that hepatic hemangioma enhancement is contrast enhancement is seen in the delay images. Now we'll move to the next one, that's hepatocellular adenoma. Here A is a T2 weighted image which is hyperindence, and B is a diffusion weighted sequence. There's a restrictions can be seen, and the T1 pre-contrast non-enhancement is isoindence. Then the D is a post-contrast arterial phase. There is an enhancement is in, and after that the portal phase enhancement is reduced, but still a little bit, but it's reduced. And after that the venous phase there is no enhancement. So hepatic adenoma here, the appearance, the T1 appearance can be variable actually. So T1 it can be usually it will be hypoindence, but there is a chance for ISO also, but it can be vary here. And the T2 is will be mildly hyperindence. T2 will be hyperintensity. Diffusion restriction will be there. Then the contrast arterial phase enhancement can be seen. So in this case, hepatocellular adenoma, arterial enhancement can be seen, and there is no any enhancement in the delayed phase or the venous phase.
That's all about the class. Hope you understood. If you have any doubts, you can contact me through the mail ID which is there in the description. Thank you all.